very common adverse effect during the induction process, I think we all can agree upon, is apnea, or when a patient stops breathing. In general, our induction agents are also going to depress the patient's mentation, which will further delay their response to hypoxemia. So while this effect is generally transient, meaning it's likely to resolve after a short period of time, add that to any comorbidities that may impact their normal respiratory function, and you've got a recipe for disaster. So what is hypoxemia? Well, I think at first we'll just want to quickly review the ways in which we monitor oxygen content by monitoring their pulse oximetry, or what we refer to as SpO2. This is a percentage of oxygen-bound hemoglobin found within the arterial blood. So what happens is there's oxygen within the plasma of arterial blood that diffuses into the red blood cell and then binds to the hemoglobin within that cell. Their normal percentage of SpO2 when a patient is breathing room air is 98 to 99%. And when we talk about hypoxemia, or a decrease in the oxygen percentage, we're talking about anything that's less than 95%. And then life-threatening hypoxemia, this wasn't a human study, was noted to be anything less than 90% for an SpO2. And I think that for cats it's a little similar, and dogs might be a little bit lower than that. But I always like to err on the side of caution, so I like to use 90% as my marker. The other way we monitor the arterial content is through our arterial partial pressure of oxygen, or PaO2. And what that is looking at is the amount of oxygen that's present within the plasma. So the oxygen that's not already in the red blood cell bound to hemoglobin. Normal PaO2 in patients when they're breathing room air is anywhere from 80 to 110 millimeters of mercury at sea level. Hypoxemia would be anything that's less than 80 millimeters of mercury. And the other thing to note with arterial content measurement in the plasma is that hyperoxemia can also be a thing, which is when we have an excess of 110 millimeters of mercury of oxygen within the arterial blood plasma. That is referred to as an excess of oxygen, or hyperoxemia. So when we talk about cyanosis, which is, when we have that sort of deoxygenated hemoglobin that's causing that, grayish to bluish pigment within the mucous membranes, we're noting that that doesn't happen until roughly 5 grams per deciliter of hemoglobin has become desaturated or deoxygenated. And the ratio to figure out, normal hemoglobin when you're looking at your patient's packed cell volume, or PCV, it's about 1/3 of your PCV percentage. So if we were to have a patient that has a hemoglobin of about 15 grams per deciliter, that equivalates to a PCV of about 45%. Now, if we've lost 5 grams per deciliter of that 15 to get to the point where a patient becomes cyanotic, this equals a hemoglobin of 10 grams per deciliter, or in this patient's ratio, drops their pulse ox by 1/3. So now our SpO2 will give us a reading of 67%. And then our PaO2 is going to drop to about 37 millimeters of mercury. So the take home with this, for anyone that was able to follow along, is that when we see our patients looking grayish or bluish, they're severely hypoxemic at that point. So using the mucous membrane or the tongue color as a marker to determine that the patient is desaturated and needs oxygen, it's already way beyond the point where we should have been supplementing our patients. And it's also, in recovery, not a good way to determine if a patient needs oxygen supplementation or not. And we'll get more into that in another episode when we talk more about recovery, but I just want to make sure to reiterate the point that blue and purple grayish gum color is bad, very, very bad. So we shouldn't be seeing this with our patients during the induction process. The other thing to note is if you have cyanosis in a patient that's anemic or already has a really low hemoglobin level, as well as, their PCV, when you take away 5 grams per deciliter, if a patient has, say, 8 grams per deciliter of hemoglobin, that's a PCV of about 24%. If you take away 5 grams per deciliter, you're under 50% of that patient's hemoglobin is getting oxygenated, I mean, that's lethal at this point. So really, really important that cyanosis is not a good way to determine whether or not your patient is going to need oxygen supplementation. So it's much better to either get an arterial blood gas, and if you don't have the ability to do that, then just getting a pulse ox is important in our patients. So then the question becomes, how can we prevent cyanosis from happening during the induction phase of anesthesia? So when we're looking at SpO2, since that's a concentration or a percentage, once we've had all of the hemoglobin bound within their arterial blood, we can't really go higher than 100%, right? So there's really nothing we can do to affect the SpO2 when we're talking about improving their oxygen content before induction of anesthesia. But what we can do is we can increase their PaO2 levels. So we're essentially creating a higher oxygen reserve for our patients within their arterial blood. So your PaO2 refers to the available oxygen within the plasma of the arterial blood. So fun fact, because I love fun facts, is that when you have a patient hooked up to your anesthesia circuit, their PaO2 values actually increase to upwards of 500 millimeters of mercury. And why is this? So that kind of leads me into the next thing I want to talk about, which is fraction of inspired oxygen. So fraction of inspired oxygen refers to the percentage of oxygen within the volume of breath that's entering into our patient. And so room air, our FiO2, would be 21%. So what are some ways that we can increase our FiO2? Well, one of those ways is by flow-by oxygen supplementation. And this is where we have an oxygen tube connected to a flow meter that's attached to an oxygen source, and we adjust the flow rates from anywhere from 0.5 to 5 liters per minute. We can increase our oxygen or our FiO2 to 25 to 40%. And this is by having that hose up against the patient's muzzle. The next option we have is via a face mask, where we can better control the volume that they're breathing in, because we've got a mask sort of containing that inflow of oxygen. So our patient's breath is more controlled. So we're getting probably 35 to 60% FiO2, and that's using flow rates of 2 to 8 liters per minute, keeping in mind that it is kind of proportional. So if you have a patient that has a larger chest volume, they're going to need higher flow rates, and their FiO2 is probably going to be lower than if we have patients that are very small, that are on higher oxygen flow rates. Their FiO2 is going to be much larger. The other option we have for increasing FiO2 is actually via our oxygen cages, and we can set the FiO2 directly on the cage's interface, and usually that's anywhere from 25 to 50%. And those flow rates are a little bit more variable, and they can be as high as 15 liters per minute, so definitely using a lot more oxygen resource via that method. The other methods that we look at are a little bit more invasive, so not necessarily the best option to use for a patient prior to the induction of anesthesia, because the last thing we want to do is increase their stress during the induction and intubation phase. But those options include either nasal or tracheal insufflation, where the oxygen is being introduced either in the nasal cavity or directly into the trachea as well. Options for doing this often include just placing a nasal cannula up into the nasal pharynx area if you're doing nasal insufflation. And if you were to advance it further into the oral pharynx, you could actually go into the trachea and do direct tracheal insufflation. Or there's even an option where you do transtracheal insufflation and you direct the catheter from the neck into the trachea that way. Those options are typically tracheal insufflation, I should say, is more commonly used in patients that have some form of upper airway obstruction and can't get oxygen in through their either oral pharynx or nasopharynx region. They're less commonly used as pre-oxygen, like I said, and also they have increased risks associated with creating lesions on the nasal mucosa, and this happens because there's higher oxygen ejection from the fenestrations of the nasal cannula, and the lower the fenestrations present on the nasal cannula, the more risk we are for these lesions, and these lesions can also trigger inflammation and swelling, and so it can actually reduce the ability for airway flow, especially if you're going into the nasal passage, which can be pretty narrow to begin with. So not the best option to use, and ways to reduce the risk of lesions would be using cannulas that have higher fenestrations present and lower oxygen flow rates. And then our last option for increasing FiO2 is actually in regards to the anesthesia machine. So when we have a patient intubated and attached to an anesthesia circuit and we're using oxygen as our gas carrier for our inhalant, that FiO2 actually increases up to 100%. And so the reason we see a PaO2 during anesthesia, 500 or higher, is because we're giving our patient 5 times what we would see with room air. So we're going from about 21% up to 100%. So normal PaO2 goes up to 110 millimeters of mercury, and if you multiply that by 5, you're getting up to 500 or more for a PaO2. So that is what we typically see during anesthesia. And another reason why we could have a patient that has, pulmonary alveolar gas exchange issues, whether it's through atelectasis or other obstructive patterns, or conditions, but we don't actually see a drop in their pulse ox until after they're extubated, because they're getting such a high concentration of oxygen that their arterial content, even if it's 250, is still enough oxygen present to properly saturate those hemoglobin and maintain your pulse oximetry at 100%. And I will stop there because reviewing that information with regards to alveolar and pulmonary disease, I would like to review in a future episode. And another fun fact that is a little off topic, but still something I would like to pass along. For those of you in practice that are placing nasogastric tubes, the determining factor of likelihood of passing your catheter into the trachea versus the esophagus is actually dependent on how you position your patient's head. So if you were to take your patient's head and neck and flex their neck so that their head or their nose is sort of more down towards the thoracic inlet, you're more likely to advance your catheter into the esophagus, versus if you were to have the patient's neck extended, or if they're sitting looking up to the ceiling, you're more likely to advance your catheter into the trachea. And why this is important is a lot of times when we're placing NG tubes, we're actually doing it blindly. So we're not using any sort of endoscopy. Our patients are usually either too sick to sedate or at an increased risk for regurgitation. So we're usually just generally giving them a little bit of medication to take the edge off, or maybe gently sedating them so that they're still alert and not at risk for regurgitating. But what that can do to our patients is sometimes reduce their response to accidental tracheal intubation. So if you were to pass that tube, the cannula accidentally into the trachea, they might be less likely to cough. And so obviously the last thing we want to do is inadvertently send a catheter that is intended to go into the esophagus, into the trachea, down into the alveoli, and causing any sort of trauma there. So having the head positioned in a flexed position with their neck will increase your success of getting that tube passed into the esophagus. So next thing I want to go over is actually talk about 2 studies that were done. One was in 2009, and it was part of the American Journal of Veterinary Research. And what they looked at is they looked at a group of healthy dogs that they provided pre-oxygenation to, and then they had the other group, or the control group, where they did not provide any oxygen supplementation to. These patients were sedated with acepromazine and morphine, and then they were induced with propofol, and they looked at the time it took to desaturation between the 2 groups. So what they did is they had 3 minutes of pre-oxygenation in one group versus the other group that was just breathing room air for 3 minutes before they induced anesthesia with propofol. And because each patient's weight varied slightly, had the flow rate at 100 mils per kg per minute. So they were dosing it off of the patient's weight so that the ratio was going to be about the same for each patient. And they provided the pre-oxygenation via face mask, and they monitored things such as the PaO2 and SpO2, and then induced them with propofol. They did give a high dose, 6 mg per kg, so I have to imagine that these patients were apneic for quite some time. The duration of action of propofol is about 6 minutes, and so, you know, these guys were also sedated with morphine and acepromazine ahead of time. So it didn't say, or I didn't look in to see the time it took for the patients to take a breath, but what they were monitoring specifically was once the SpO2 dropped to 90%, which was their consideration as a desaturation point, then they actually connected them to the oxygen within the breathing circuit and breathed for them and got them up to 97% for an SpO2. And they also looked at their arterial blood. They collected samples, you know, throughout the study as well. And what they found was 70 seconds was the time to desaturation it took for patients breathing room air. So what does this mean? This means if you're inducing your patient and they become apneic, you have about a minute to get these guys intubated and onto your anesthesia circuit and breathing for them before they're going to desaturate. Now, propofol takes an onset of about 45 to 60 seconds. So it takes about a minute to get to that point where you've given enough propofol and your patient is sedate enough for you to be able to intubate them. So now you're sort of at zero marker, right? Your patient's desaturated to about 90% by the time you're getting ready to intubate them. If there's any difficulties with intubating them, you have no reserve, no wiggle room of getting these guys intubated before they're dropping and becoming cyanotic. If you pre-oxygenate your patient, in this study, for example, they did 3 minutes of mask oxygenation, you increase your time to desaturation to 5 minutes. That's pretty significant. So now your patient, you're giving yourself about a 4-minute wiggle room after you've given your propofol or whatever co-induction agents you use. You're giving yourself a little bit of a buffer if this is not a straightforward, easy to do, you know, intubation. So pretty significant. Now, the other study I wanted to look at was published in the Journal of Veterinary Anesthesia and Analgesia, I believe in 2018, and it looked at the difference between pre-oxygenation via flow-by or face mask and what those FiO2 percentages were. And they actually had a transtracheal probe into the trachea that was sampling air that was there and determining what the FiO2 was. So this is probably the most finite way of finding out what your FiO2 is, because they're pulling it directly from the source, right? Like they're pulling it from the air entering the trachea, which is then going into the, you know, bronchi and alveoli. So you can't really get more accurate than that. And what they found, and in these patients, again, they kept the control by having the flow rate is the same dose per patient. So it was 100 mils per kg per minute. And they used both methods. And so FiO2 in the patients that were provided flow by was around 30%. So not significantly more than our room air, which is FiO2 of 21%. While they actually got face mask FiO2s of upwards of 90%, which is crazy, crazy high, and probably more than what we had expected or had noted it to be in the past. So that is why, you know, it's recommended that if you're doing pre-oxygenation for your patients, you're actually using a mask. It's much, much more effective for these patients. Now, the desaturation point, so again, they use 90% as their SpO2 for, you know, marker for their desaturation point. So time to desaturation averaged from around a little more than 3 minutes for your mask. So this one noted 3 minutes of pre-oxygenation via mask gave you about a little over 3 minutes of time to desaturation. So a little less than the other study. But it did note that doing the flow-by technique, actually your time to desaturation was a little over a minute, so 66 seconds. So really not much difference than in the first study that said it took a little over a minute for the patients to desaturate. So takeaways from these two studies: 3 minutes of pre-oxygenation gives us about 3 to 5 minutes of time before our patients will reach a desaturation point of 90% on our pulse ox. The 90% desaturation point does not mean cyanosis. If your patients are becoming cyanotic when you're intubating them, your patients are not at a desaturation point of 90%, right? They're probably downwards in like the low 70s, high 60s, or even lower if they're anemic. So really, really significant. The last takeaway from this is I just wanted to make note that, you know, flow by oxygenation, it might not be the best option when providing oxygen supplementation to your patients that present to your clinic or your hospital that are hypoxemic, you know, because you're not really increasing their FiO2 very much. And if they're already struggling and you have to get a catheter in them or anything else that you need to do diagnostic wise, if you have the option to use a mask, it's far superior than using the flow by technique, especially if the patients are larger. Now, obviously, we don't want to get too close to them if they're going to be aggressive or really stressed. And sometimes you have to just give patients, you know, a little bit of oxygen support, maybe in a cage if you have that, or give them some drugs to sedate them a little bit so that they're less stressed, because stress can certainly exacerbate their respiratory distress. But it is, you know, if you don't have a mask option, I wouldn't say, you know, go up to your patient and be like, oh, well, I'm not going to do flow by because it really doesn't do that much increase in FiO2. Well, that's not the reason to not do it, right? If that's the only option you have in your clinic, then absolutely use flow by oxygen. But if you have a way of getting masks into your clinic, that is probably going to be a cheap option to really positively affect your patients when they come in respiratory distress. You're going to be helping them a little bit more. So just another takeaway, you know, for oxygenation, you know, in patients that are not necessarily surgical candidates, but that present, you know, to your clinic in distress. So my episode challenge to you: can you intubate your patients before they turn blue? I didn't mean for that to rhyme, but it did. So we're getting the end of our episode, and today's CARES action is going to be saying thank you. So I'm encouraging all of us to say thank you more this upcoming week, saying thank you to a family member, to a friend, and more importantly, to coworkers. Now, if you're someone that on a daily basis does say thank you quite a bit, then my challenge is going to be, can you say thank you to someone that you've never said thank you to before? Maybe it's your boss, maybe it's someone in management, maybe it's a you know, someone on your team that is new, or that maybe you don't get along with very well, but you know what, there's something that they do well. Call them out on it, say thank you for being you. It really could make someone's day. You know, say thank you to the custodial team, to people that are cleaning up and making sure that the cages are clean so they're not passing, you know, infection from patient to patient. Find someone within your hospital that you can call out and say thank you to, and let me know how it goes. I'd love to hear from you. And if you have any other recommendations for CARES actions, you know, please reach out. And this concludes an episode of CARES. Thank you so much for listening in, for making it through the end of the podcast. I would love to hear from you. I'd love to know how I can make the show better, what you've liked about it, what you didn't like about it. You can reach me, caresvetmed@gmail.com. You can find the podcast on Apple, Amazon, as well as YouTube. I'm working through Spotify. There's a little bit of kinks that I have to figure out, so that is not quite available there yet. I also have a website we're working on, caresvetmed.com, which the goal is to have the YouTube episodes on there as they come available, but there might be a little delay to that. So you can go to YouTube directly. We're at CARES Vet Med. You can also connect with us on Facebook, Instagram, as well as Twitter. We are also on TikTok, although I'm still figuring out how that interface works. And that again is at CARES Vet Med. Thank you so much for listening in. I'd love to hear from you, love to connect with you. I'm Tracy Mahoney. Take care, friends.